And the BRAF mutation plus MSI really suggests that these are somatic mutations, not germline Lynch syndrome or hypermethylation of MLH. Yeah. This is that key to sort of understanding about testing for Lynch for these patients.
I think it's very important that MSI trumps BRAF in that situation, and I mean trumping, okay? So meaning that when you have immunotherapies, it doesn't matter if they're BRAF mutant, it doesn't matter if they're methylated phenotype, it works the same. Yeah. Which is amazing. How can MSI overcome this incredible prognostic factor? Which is another mystery, we don't know, but it's a very good time. But when you look at BRAF mutant without MSI, they have features of MSI signatures. So there is something, it's not a coincidence that 30% are the same. You know, you have BRAF mutant, 30% of them have MSI. So there is some common background genetically.
Yeah. And thinking about special populations, I mean, Zev, everybody's talking about HER2. I thought you're just supposed to treat, find out if breast or gastric cancer patients for HER2. What does this mean for the world of colon cancer?
I mean, first of all, it's pretty rare in colon cancer. If you look at the data, it's dependent on what you read, 4 or 5% maybe. Predominantly and almost exclusively, it's going to be RAS wild type patients that are certainly in my opinion, no reason to test a RAS mutant patient for HER2. They're usually left-sided. And most of the excitement, I would say, came from the Italian study, if I'm not mistaken, combining trastuzumab and lapatinib without chemotherapy. And now there are a number of newer HER2 targeted therapies, whether there's a SWOG trial that's looking at the combination of Herceptin, or trastuzumab, I should say, with chemotherapy versus cetuximab as control. And there's second generation HER2 ADCs that are very exciting and potent drugs that are also looking particularly at HER2 CRC, because it would be a rare group within presumably a response rate, a high enough response rate may be sufficient for us to get some sort of accelerated path towards approval if it can be demonstrated in that group. So I think, we haven't had any new target, so to speak, and this is not a new target. This is about one of the oldest targets we have, but it's repurposed here, and in those patients now, I think there's some suggestion that some HER2 blockade may make sense. So why not check it? It's easy enough to do.
True. And so, Dirk, if you check first-line therapy, you have a HER2 positive patient, and they're left-sided, does that influence your choice of whether or not to use an EGFR inhibitor in these patients?
Well, yeah, I think the decision is then to go with the EGFR inhibitor because it's likely this patient is also RAS wild type. And so therefore, I would clearly use an anti-EGFR receptor inhibitor given the good evidence for this in this situation.
So you would use it for a HER2 positive patient, use the EGFR inhibitor? Is Heinz?
I probably would not, because it's one of the mechanisms of resistance. So I probably would safely give BEV, but we don't know because it's one of the escapes. So that's the reason you combine both in the SWOG trial with the patritumab and the cetuximab. So the HER2 positive I would use with a combination of HER1 and HER2.
I mean, definitely controversial, as you can see here. I mean, there's some data that suggests potentially that they might not be
But I'm getting always
yeah.
also caught up, should I do it or not? But then,
Well, now let's get into the real.
Let me say, we have to learn a bit more about, let's say, also the predictive quality and really what the outcome with the anti-HER2 treatment is. Yeah, since we have seen this terrible failure of all these drugs, which work so nicely in anti-HER2 management in gastric cancer, which works so nicely in breast cancer. Yeah, double inhibition, all these elegant principles, which really brought such a gain for patients with breast cancer, and we learned that this is something different in gastric cancer, and I'm not sure what it means in colorectal cancer.
So I think we know already melanoma is different than colon cancer, and gastric cancer is not the same than colon cancer. So one of the biggest issue in HER2 breast versus gastric, in gastric you lose HER2 under treatment. 60 to 70% you lose the amplification or the expression. That's the reason the second line, what works in breast, do not work. It's not they don't work, the target is not there anymore. So I think that's the reason we cannot translate one to the other, and we need to learn more about the dynamic, because what I recently saw is actually also interesting. So when we have a HER-negative tumor, it can turn positive. So it goes both ways, and I think we'll learn more about the dynamics, and If there are treatment implications, I don't know, but it is very an interesting fact because we think it's negative, it's negative. It's not true. It's not true anymore.